So thank you to everyone for their time today, and welcome to the OzSAGE releases for advice on mask use, safe indoor air in schools, and COVID-19 control. I'm Dr. Kalinda Griffiths. I am a Yarwoo woman, an epidemiologist at the Centre for Big Data Research and Health at University of New South Wales. I'll be your host for today. Before we begin, I would like to acknowledge the traditional custodians of the many lands on which we're meeting here today. I'm coming to you from Darwin, the Northern Territory, upon whose lands the Larrakia people are from. These lands are in a country where sovereignty was never ceded. And so I pay my respects to all elders, those of the past, the present, and the future. OzSAGE is the Australian Scientific Advisory Group for Emergencies and was founded under the premise for providing scientific evidence to ensure that no one in Australia is left behind in this pandemic. There are a number of renowned and leading experts on the group across a range of disciplines, including medicine and primary care, engineering, data science, epidemiology, public health and economics, just to name a few, all of whom volunteer their time to independently provide the most up-to-date, relevant, evidence-based advice for the community and businesses, as well as federal and state and territory governments. Today, OzSAGE releases 3 documents. 2 advice documents, the first on masks and the second on community partnerships, and 1 response to the New South Wales Department of Education's position on air purifiers in schools. So the following OzSAGE experts will be talking at today's press conference. I'll present the weekly stats update. Professor Anne Kavanagh, epidemiologist and chair in disability and health, will provide the update of the disability sector. Dr. Michael Doyle, an Aboriginal health researcher, will provide an update on Aboriginal and Torres Strait Islander health. Jeremy Howard, co-founder of Masks for All, will deliver OzSAGE advice on masks. Dr. Faisal Nefta, PhD scholar at the University of Sydney, will talk to the OzSAGE advice on community partnerships. Anaesthetist Dr. Andrew Miller will discuss deaths at home and risk tolerance. And occupational hygienist Kate Cole will provide the OzSAGE response to the New South Wales Department of Education on safe indoor air in schools. So there's quite a few people to get through here today. And so the members will take questions at the end of the presentations. Firstly, the weekly stats update. So there have been 11,982 reported community cases in Australia over the past week. This is a reduction since last week, but the case numbers are still high, with the highest case numbers being 1,881 on September the 15th. These are still mostly due to outbreaks in New South Wales, Victoria, and the ACT. And we're also seeing continuing high case numbers for younger people, with 52% of all cases in people below the age of 30 years. So COVID-19 is a disease of the unvaccinated, so there will be increasing numbers in these age groups due to the delays in the younger populations receiving vaccines. Good news is that vaccination rates across the nation are improving, with rates increasing nationally by 4.4% since last week. So this is going from 42.3% to now being 46.7% of people over the age of 16 years now being fully vaccinated. So we are getting there. So next slide, please. This is the doubling time, and the doubling time shows how quickly the outbreaks in the selected jurisdictions are doubling over time. So the x-axis shows the dates by weekly intervals, and the y-axis shows the doubling time, which is in how many days it takes to double based on the case numbers. What we want to see in this graph are the lines going up, because this indicates a slowdown in COVID-19 transmission within the jurisdictions. So this is a good news graph, with New South Wales and the ACT continuing to have upward trends in doubling days. And this week, Victoria has a slight trend upwards after a dip in doubling days, which is really very reassuring. So next slide, please. And the nation has had 66 COVID-19 reported deaths in this past week. And we can see that the majority of deaths occurred in people over the age of 70 years. And 5 deaths were linked to outbreaks in aged care settings. So 5 deaths occurred while people were at their homes, and 3 deaths also occurred in people in their 20s. So 1,470 people were hospitalised, 244 were in ICU, and 162 people were on ventilation. And so the majority of these patients were in New South Wales, and this was followed by Victoria. And we're going to see this trend as these outbreaks continue on as well. So these numbers will decrease as vaccination rates increase across the nation, which is what we're hoping to see. I'm going to go to our next speaker now, Professor Anne Kavanagh.
Hello. I'd just like to pay my respects to the Wurundjeri people of the Kulin Nation, on which I am today, and to their elders past, present and emerging. So if you could bring up my slides, thanks. So what I'm going to talk about is just the disability sector vaccination rates and some of the issues for them in relation to current opening up strategies in New South Wales and Victoria. So just to remind everyone that in phase 1A, the most highest risk phase, there was a commitment to vaccinating disability staff that worked in residential settings like group homes, as well as residents of group homes. And then later, younger adults with an underlying medical condition, including those with disabilities. So a large proportion of people with severe disabilities will actually have underlying medical conditions, a large proportion of people with disabilities per se. And although we didn't see this play out in Australia in last year, in the United Kingdom, 60% of deaths were among the 17% of people who had disabilities. People with disabilities were 3 times more likely to die, and people with intellectual disabilities 8 times more likely to die, with some particular groups like people with Down syndrome being 36 times more likely to die of COVID-19 in the UK. Next slide, please. So this just shows you rates of vaccination among these priority groups. So this is national rates. You can see that although it was an incredibly slow start in disability residential settings, it's now up towards just under 75% first dose. But remember, those folk are in phase 1A. And then in the general population, it's a little bit over the general population, but potentially slowing down. Among NDIS participants, who are just 10% of people with disability and would predominantly be in phase 1A. Sorry, this is American style date on the bottom. You can see there's at least a 10% difference in rates with the general population. Disability screened workers are tracking in terms of first doses at about the general population rate. Next slide, please. So I just want to give you some ideas of the differences in nationally here, just about 10% difference. If you look on the left-hand side, there's the national rates, and then there's the rates among people who are NDIS participants, who may or may not live in residential care, predominantly not, about 10% lower their first dose and about 4% lower second dose. That's significantly lower than what's happening in first doses in New South Wales. There's 80% first dose and only 66% first dose among New South Wales NDIS participants. It lags by 14% and about 7% in Victoria. So it's very unlikely that NDIS participants who were in phase 1B will reach the 80% double dose when New South Wales, or 70% double dose when New South Wales is relaxing restrictions. Next slide, please. I just wanted to emphasise that there is data out there supposedly about what's happened in the among NDIS participants, but it's quite clearly an undercount of what's happening. The data is reported by disability services, so they're clearly not all registered providers are reporting that. And I just wanted to show that at the time in Canberra, when there was a report that there were 45 cases in the disability sector, if you look at participant active, they said there were 10 in that report. There are 5 on the dashboard. And likewise, there are over 30 in workers, but there are only 13 on the dashboard. So actually, going by that, we would expect there are actually many more cases in New South Wales, and we know that there are quite a few outbreaks happening at the moment in group homes. There also has been at least an increase in 3 participant deaths in the last week, because that number for New South Wales was dashed before, and so that was under 5, because that's a cell count they're not allowed to show us. So actually that means it's 4 as of today. So some of the deaths you heard about have actually happened in NDIS participants among people with disabilities, but then that is also likely to be an undercount for the reasons that I've said before. So it's critical that actually there's a much more rapid uptake of vaccination among people with disabilities and support workers. Thank you.
Thanks, Anne. It seems like a lifetime ago we had phase 1A, 1B, 2A and 2B. It's a very well thought out idea in which how we should do the vaccine rollout in our country. So my name is Michael Doyle. I'm a Bardi Aboriginal man. I work in Aboriginal health research and have a background in public health. I want to acknowledge the traditional owners of the land upon which we're all meeting today. I'm here at home in Redfern, so I pay my respects to the Gadigal people of the Eora Nation. And I pay my respects to elders past, present and emerging, as well as all Aboriginal and Torres Strait Islander people online today. So as of the 16th of September, there were 1,877 cases among Aboriginal and Torres Strait Islander people in New South Wales since the start of the June outbreak. 681 of these cases are in West and Far West New South Wales. We're aware of 3 deaths, and there is vaccination data for around 1,600 of these cases, and more than 99% were unvaccinated. The total case numbers across Australia for Aboriginal and Torres Strait Islander people are now over 2,000 since the start of the pandemic. So vaccines are being rolled out across the country, and it's pleasing to see that the rate of vaccination is increasing among Aboriginal and Torres Strait Islander Australians, particularly in New South Wales, Victoria and the ACT, where there is vaccine urgency. However, we still have a way to go to ensure that 90 to 95% of all Aboriginal and Torres Strait Islander Australians are fully vaccinated. Nationally, as of the 19th of September, almost 43% of Aboriginal and Torres Strait Islander people aged 12 years and older had received at least 1 dose. Almost 25% were fully vaccinated. This shows there's still a gap in the vaccine rates that must urgently be closed. We know there are additional efforts underway with governments working with Aboriginal community-controlled health services and their peak bodies towards increasing the rate of vaccinations of First Nation people. These efforts have been prioritised within New South Wales, Victoria and the ACT, where these jurisdictions are currently on track to having over 80% of Aboriginal and Torres Strait Islander people over the age of 12 years to having at least 1 dose of vaccine. However, further effort is clearly needed. For historical and contemporary reasons, there is a distrust of authorities by many First Nations people, which is why it is one of the recommendations of the OzSAGE working group that Aboriginal and Torres Strait Islander people should be central to the decision-making at all levels and to lead and support efforts to improve vaccine uptake. We are 18 months into this pandemic in Australia, and people are getting tired, and many are, but to put it simply, just over it. This does not mean that we take the easy road and give up or ignore the evidence, We encourage everyone to stay strong, to get tested for COVID, even if they think that, to get tested for COVID if they think they may have been exposed, or if they have the mildest of symptoms, and to get vaccinated as soon as possible. People with COVID can deteriorate very quickly, and anyone who is feeling unwell should seek help as soon as possible. We will provide the contact numbers at the end of this statement and on the OzSAGE website so that people can have a yarn to a health professional and if they're feeling unwell or if they're feeling sick. So mask wearing. Mask wearing continues to be a major part of the response to reduce the risk of transmission of COVID-19. All levels of government need to work towards ensuring masks are affordable and that there is adequate supply of masks for all Australians. This is particularly important for people who may not be able to afford the ongoing costs of masks, and also for supply to be provided to people in regions where there are limitations to access and supply of masks. COVID-19 travels with humans, so masks should be worn, in addition to other prevention measures such as vaccination and social distancing measures. It's important that COVID-19 mitigation measures that are developed for when school returns also include specific advice for Aboriginal and Torres Strait Islander people and communities. This should reflect the known higher risk factors for Aboriginal and Torres Strait Islander children and youth, and identify and address the potential risk of transmission in the school environment. No matter where we live, whether it be here in Redfern, Cairns, Broome or Juddingham, Aboriginal and Torres Strait Islander families and communities are all interconnected. Before restrictions are eased and road travel is open for non-essential purposes across jurisdictional borders and into regional and remote areas, vaccine rates in these areas need to be in the 90 to 95 double dose range. Until then, governments need to work with Aboriginal communities and support restrictions until communities are protected. We recommend that all people over the age of 12 years, including people who are not Aboriginal and Torres Strait Islander, who wish to travel to regional and remote areas to be fully vaccinated. Our connectedness gives us strength. In order to leave no one behind, we must work together to ensure we are all safe. Thank you, and can you put the contact numbers up, please? So these are the numbers that will be available on the OzSAGE website a bit later. Thank you.
And we'll now go to Jeremy Howard.
Back in April of last year, 2020, I was the lead author of the first and largest evidence review academic paper looking at the effectiveness of masks against COVID. We've come a long way since then. And back in April of last year, we were very focused on the effectiveness of simple masks such as homemade cloth masks, because that was all that was available. And we did in fact find that they were quite useful. In particular, they're useful at protecting other people from the mask wearer in case the mask wearer is infected. I'm really surprised to say, though, that here, 18 months later, in September of 2021, Australians are still wearing those lower quality masks, despite the fact that there are much better options available. So OzSAGE's recommendations regarding masks really focus on people using better masks and using them in better ways, and also making sure that they're used more widely. Believe it or not, with the simple things that I'm going to describe today, it's possible that we may have avoided these outbreaks in the first place. They could really cut down transmission quite significantly and also greatly reduce the number of deaths and hospitalizations. So the first recommendation from OzSAGE is about these kinds of masks. These are surgical masks, and surgical masks were never designed to protect people from respiratory infection. And so here's the problem with surgical mask. If I put it on, you can see that there's big holes in the sides. Now, remembering that COVID is airborne, so it's kind of like cigarette smoke in the air. So if you use this kind of mask, when you breathe in, all of the virus can just get sucked straight in through the sides, through those big holes. And so this is a big problem. And this is why these kinds of widely used masks in Australia, although they can help protect others from you, they don't do much to protect you, the wearer. So instead, what we recommend is that people who are using this kind of mask put a small knot in each side like this and tuck the fabric through. And so if you wear this kind of mask, as you can see, the gap totally disappears. Now, these kinds of masks are not perfect, but amazingly enough, there was a recent research study coming out of the CDC in the US, which actually shows that if everybody in a room wears that kind of mask, the amount of transmission will be reduced by a factor of 10. So it's something that can reduce the transmission by the amount of virions getting passed through by a factor of 10. That's a really big deal. And this is something that's totally free. It doesn't cost anything. It takes 30 seconds to tie that knot. Why isn't everybody doing it? Another option is to wear one of those surgical masks, but put a cloth mask over the top. And so the thing about most cloth masks is that they're much tighter fitting. And so the CDC study that I mentioned actually shows the same thing. If you wear a normal surgical mask with a cloth mask over the top, you get that same factor of 10 reduction in transmission. So it sounds like such a simple, small little thing, but just imagine a factor of 10 reduction in transmission is day and night. This could be the difference between an outbreak continuing and needing lots of lockdowns and continual deaths and it petering out to nothingness. So our first recommendation from OzSAGE is to use one of these two techniques. The first technique I mentioned is known as knot and tuck, and the second technique is known as double masking. To get another additional factor of 10 improvement, use a better mask. Now, in the early days of the pandemic, we didn't like people to be using medical respirators because healthcare workers needed them and there wasn't enough medical respirators. Today, the world is full of medical respirators. Industry has stepped in and there's all different kinds. For example, this is called a KF94. This style is designed and standardized in Korea. And I'll show you what it looks like when I put it on. And as you can see, it's got really fantastic fit on all sides. And the material it's made of is explicitly designed, not like a surgical mask, which is designed to stop droplets, but this is designed for respiratory protection. There are other examples, such as the well-known N95 mask. These are a much more kind of heavyweight option. Personally, I find them a lot less comfortable, but they certainly work very well, but they're also more expensive. So OzSAGE's second recommendation regarding masks is that we call on industry and the government to start making more of these respirators available in Australia. They're very widely available internationally. You can buy them for like $1 each if you're buying them in volume. And there's really no reason that Australians should be wearing these lower quality masks. As I said, this is an additional factor of 10 improvement. So we're talking about 100x improvement using these kinds of masks versus just a cloth mask or surgical mask alone. Those kinds of respirators are commonly described as disposable, and in a healthcare setting, people do indeed need to dispose of them every 4 hours or so. But in a community setting, that's absolutely not the case. Dispose of it if it's obviously dirty, if you can't breathe through it properly anymore, if it's damaged, but otherwise they can be reused. Our third recommendation is to remind people that if you don't have access to a better quality mask, at least wear something. Any kind of mask is still useful, particularly at protecting other people in case you're infected. So any mask is better than none. Our next recommendation is about schools and children. It turns out that a recent research study looked at what are the various ways that schools can be made more safe. And they found that if all of the children in a classroom wear a mask, the probability of them getting infected with COVID is reduced by a factor of 300. So using masks in a classroom is an extraordinarily effective way at keeping children safe. At the moment, in this disease of the unvaccinated, children are largely unvaccinated in Australia, and particularly the under 12s will continue to be unvaccinated for a little while longer. If we want them to go back to school and we want to keep them safe, then we need to make sure that they're safe in their classrooms, and ensuring that they are wearing masks is a very good way to help in that direction. Unfortunately, generally speaking, mask usage and mask compliance is poor in Australia and most Western nations without mandates. So we actually recommend that mandates are in place for the use of masks in schools. Our final recommendation is around government investment. We want to make sure that everybody has access to masks and can afford them, and therefore we call on the government to invest in local manufacture of masks and importation of foreign masks to ensure that everybody can access this really important public health tool.
Thanks, Jeremy. So just before Dr. Nefta starts, I'd like to note that the community partnership advice document is intended for a range of communities, and the examples of the communities are provided within the document, whereas her presentation will focus on culturally and linguistically diverse communities. So I'll pass you on to Dr. Nefta now.
Good afternoon. Thank you for giving me this opportunity to talk today. I am a PhD researcher at the University of Sydney. I am from a cultural and linguistic background here in Australia. Australia has had increased cultural and language diversity following successful waves of immigration. Statistics show that over 300 separately identified languages spoken in Australia homes. The culture and language are evident communication barriers in cold communities. So these communication barriers need to be addressed for improving public health messaging, healthcare accessibility, and acceptability of healthcare advice to prevent ongoing outbreaks. Cold communication and COVID response. COVID-19 outbreaks are not equal distributed and have disparate impacted on underserved population. Cold communities are at high risk of COVID-19 infection. So these groups often face barriers to accessing healthcare, including preventive health care such as immunization, many-phase, multiply, and intersecting forms of structural discrimination. So translation of information for this community and using trusted messengers to deliver the information by communities leaders or religious leaders. Appropriate communication methods to accessible by cold communication. Working in a partnership with communities. Why we need to work in partnerships with community? To ensure that no one is left behind. Education strategies should be tailored to communities based on their specific information needs. Understanding of and engagement with these communities to assist change their behaviors. Next, please. Recommendations. There are three components of the COVID response that are influenced by human behaviors. One of them is vaccine uptake and prevention of transmission through adhering to non-pharmaceutic intervention like lockdown, wearing mask. Then maintaining a high level of tests for COVID infection tests so that outbreaks can be detected and managed. Next, please. Recommendation from OzSAGE group for action. In the recommendation that barriers, language and cultural barriers for these communities should be addressed in the form of misinformation and false vaccine narrative through the development of target resource and tools. And then a second recommendation, co-design partnerships between communities, public health practitioners, and behavior scientists to identify this barrier and address these barriers to language and cultures. Enhancing the communities are empowered and resources to engage in co-designed intervention, development, and delivery. Enhance the collection of data. One of the next recommendation, enhance the collection of data on COVID infection, health outcomes, and vaccination to help to identify specific of these community needs. Thank you. Thank you for listening.
Thanks, Faiza.
Thanks.
And lastly, we have, oh no, sorry, second last, we've got anaesthetist Dr. Andrew Miller. You're on next.
Hi, thanks and welcome everybody. Thanks for your time this afternoon. I pay my respects to the Whadjuk people of the Noongar Nation here in the grand final state of Western Australia. Really appreciate the opportunity to have a bit of your time to talk to you about some risk analysis. So if we could have the slides up, please. There's been some suggestion in various places that perhaps we're a conservative group who are a bit risk averse, and I think it's reasonable to talk a bit about a risk analysis and what that means. And my background in anaesthesia is, of course, oxygenation, ventilation, and critical care risk assessment, but I also have some experience in medical legal liability and in corporate governance. So let's go into the next slide, where I wanted to talk a bit about what's happening with deaths at home in New South Wales. And this is obviously one of the risks that needs to be managed, and a good example of something where you have to analyse how can we do better with this that is not demonstrating that people are unnecessarily nervous, but clearly this is something that needs to be remedied where possible. We know that the main risk of people is being at home with COVID is that they will suddenly and unpredictably deteriorate due to severe pneumonia, which can evolve very rapidly in someone who appears to be reasonably well. We can sometimes call them the happy hypoxic people. They seem okay, but when we measure their oxygen level, it's almost unbelievably low. Now, some of these people might not survive even if they were in hospital when this happened, but some of them can be saved if we've identified them and we're managing them at home with pulse oximeter saturation monitoring, which is just that little peg that goes on your finger when you go to hospital, very simple device that is actually not expensive either. And I understand that some people are being looked after in hospital in the home that way, having intermittent checks, but full-time checks for everybody would be better. This whole system relies on there being able to be a rapid response if someone is deteriorating. And at the moment, we're having real trouble, as I understand it, in New South Wales in particular, with ambulance response times averaging out to 59 minutes or so for priority ones at some times. And so that makes it very difficult, you can see, to risk manage this and balance this whole situation. How then do you manage them? Do you give them inpatient care where you have a team hopefully available to assist them and to monitor them all the time? Well, the system can't provide that at the moment. So the best risk management in this situation is to reduce case numbers overall. That's not being alarmist, that's not being nervous about things, that's not having an excessive regard for the risks. That's just a fairly natural scientific risk analysis which comes to a logical conclusion that the case numbers are just too high for the system to cope in regard to deaths at home in New South Wales. We can go to the next slide, please. So that's why the OzSAGE value that we leave no one behind is not an unusual value. Of course, that's how emergency departments work. That's how our hospital system works, where we treat rare disease and we try to close the gap in healthcare outcomes for Indigenous people, for example. We don't want to leave people behind. It's aspirational, but it is achievable with will and resources. And when we talk about risks and how we're going to manage them, we need to look at all risks where harm could occur that's manageable. There's something you can do about it. We can manage the things that are very likely to occur. So classroom infections we've been talking about, that's 100% likely to occur if there's COVID around. Long COVID risk of 7%, that's another thing that's very likely to occur. And health system failure, clearly something in the news today where we're planning to go into overwhelm. That's something that should be managed so we avoid that. We should also manage risks that are somewhat likely, but with a very bad result. And hospitalisation of children at 1 to 2% is a bad outcome. Even if those children subsequently turn out to be well, it's a traumatic experience. And we should manage things that are unlikely but have a catastrophic outcome, such as rare deaths. Next slide, please. Fortunately, we've got good ways to manage all of these things. We just need the will and the resource to do it. And risks are much more important when they're irreversible, as COVID damage can be, and timing is crucial. At the moment, we have to consider, do we have short-term risks that will pass? So as we get more people vaccinated and we get more vaccines for younger people under the age of 12, we can manage a risk that will then go away to an extent. And we're inspired a bit by people like Sullenberger when he crashed into the Hudson River. He didn't say, right, we'll get the business class people out. That's probably enough. Let's move on. He said, let's not leave anyone behind. Next slide, please. And we can do that with our resources. So who decides what risks are okay to manage? Ethically, the people who are affected by the risk should have some way, should have some say in how it's going to be managed. We can go on to the next slide. Thanks. And what of course happens is that the politicians and so on will spin the way that they've decided to manage the risks in a way that benefits their particular narrative, because they know that they're reporting to their employer, which is the people. So they then start to emphasise, well, what are the risks of managing COVID? Is that not worse than the COVID itself? And quite clearly we're seeing around the world that no, the risks of managing COVID are not worse than COVID itself. And we'd have to look no further than Western Australia or Queensland or Tasmania at the moment. And this being divided into two countries means we have to look at these risks in a different way now in different jurisdictions and start having that conversation around, is what we do in New South Wales what we can apply everywhere? And the answer is no, we should do it differently depending on the amount of COVID that we have around. So risks of managing something, that's something we're used to talking about all the time. Medico-legally, we call it informed consent. There's pluses and minuses to having any intervention. And we've done this with vaccines, and we've done it with lockdowns, and we've even done it with mental health, and we've looked at all of those aspects. We should also be considering what we're measuring, because we talk a lot about cases and about deaths, but we should also be talking about how to measure disability and how to measure costs on the health system in the future, and how to measure years of life lost, because that's something that we take into account when we're treating disease. When I'm my age, I don't expect necessarily the same resource to be put into my treatment that I would expect to be put into a child who has a lot more years ahead of them. Next slide, please. So we're in favour of a proper and honest scientific analysis of all risks, not cherry-picking individual risks to support an argument for or against measures. And what you'll find is that some politicians in particular, when you start talking about a risk such as classroom transmission, and we need HEPA filters, we need masks, we need vaccination for teachers, we need remote learning options, all of these things, they'll throw up some other risk that's you know, just a bit woolly and not well defined, such as mental health risks or developmental or educational risks. That's not the way to do it. You have to have a proper matrix and balance them all. And they're really being a little biased sometimes in the way they're putting forward these risks. You can say only 2.6% of kids end up in hospital. Well, you can leave out the only and leave it up to parents to decide whether 2.6 is a number that is too high for them or too low for them. You can say that child deaths are vanishingly rare, but to the 140 a month or so, 110 a month or so in the US families that are affected by a childhood death from COVID at the moment, it should just be characterised as rare, not understating it and trying to put a positive spin on it. So by all means reassure people, but we don't make the decision for people, for the community about what those risks should be, and there should be an honest conversation about all these things. And it's important to remember that higher socioeconomic demographics can and do control their own risks. So in the meantime, what I would like to ask those in the media to do is, when someone mentions a risk as a reason to do or not do something, say, who's saying this? What biases might they have? Is their statistic real and relevant and consistent with what we're seeing overseas, for example, the problems we're seeing in the US in particular? Where does it fit in the matrix of all of the other risks? Is the person who's talking at risk themselves, or are they talking about it's okay for these people over here to take on that risk? And is the risk manageable? And if so, at what cost can we do that? Thanks for your time this afternoon.
Thanks, Andrew. Next up, we have Kate Cole. Kate, do you want to?
Yep, thanks very much. I'd like to acknowledge the Gadigal people as the traditional custodians of the land that I'm speaking to you today, and pay my respects to elders past and present. So we know that SARS-CoV-2 virus spreads through the air in aerosols. We also know that the risk of COVID infection is higher in indoor spaces, and it's even higher when those spaces are poorly ventilated. Poor ventilation in public buildings, workplace environments, schools, hospitals, and aged care homes contribute to viral spread. And good ventilation is one of the most effective ways to reduce the risk of COVID infection in conjunction with other mitigations, including density limits, the use of PPE, and the use of air purifying devices such as HEPA filters. In order to create safe schools, we need to focus on safe air, because airflow is a key factor in reducing the risk of COVID transmission in schools. The OzSAGE position of no one left behind includes children. It also includes children in special schools and in disadvantaged regional and remote communities. Schools can and should be made safer for them to return to. Schools should receive the same level of care and attention as other workplaces. I note that the New South Wales Parliament House has worked to improve ventilation with the plan to keep parliamentarians safe, including rapid antigen testing, physical distancing, and at least 8 air changes per hour indoors. That's fantastic. We understand that the New South Wales Department of Education are preparing COVID-19 mitigation measures for when school resumes. These include using year group bubbles to prevent mingling of many students, checking that windows operate correctly, making sure that new filters are installed in air conditioning systems, and the use of masks. These are all fantastic. It's a great first step. What we need now are measures to prevent unsafe air. So while opening windows is good, that doesn't always prevent the buildup of contaminated air effectively. But there are some very simple strategies that can be used to check this, including the use of carbon dioxide or CO2 monitors. And we have provided information on this in our OzSAGE advice on safe indoor air recently. The use of high efficiency particulate air or HEPA purifiers has been proven to efficiently remove microscopic airborne particles, including respiratory viruses, from air in high occupancy spaces like classrooms. HEPA air purifiers in indoor environments greatly reduces the concentration of potentially harmful viruses such as COVID-19 in the air. And recent statements by the Education Department Deputy Secretary suggested that persons with scientific or medical qualifications would not recommend interventions such as HEPA filters. At OzSAGE, we're a multidisciplinary network of Australian experts from a broad range of sectors, including those with science and medical qualifications, myself being an occupational hygienist and a scientist and engineer. OzSAGE offers decision support underpinned by the best scientific evidence to the Department of Education to help inform decision-making and ensure that we support the opening of schools in a safe way. As a mother myself, I want nothing more than my children to be able to go to school, and I want them to be safe while they're there. And I know that many parents, teachers, and school principals feel exactly the same way. Thank you.
Thanks for that, Kate. And thank you to all of our experts. We have about 10 minutes for questions now. And we also have a couple of other OzSAGE experts on the line as well. So if any of the journalists or media outlets representatives would like to ask any questions, please feel free to unmute and have a chat.
In the chat, so it's a question for me about when I would advise the use of HEPA filters or purifiers in schools and under what circumstances. That's a great question. The first thing we should do is to try to get as much outdoor air into our school classrooms as we can. And then we can use really simple measures like carbon dioxide monitors to see how much carbon dioxide is building up in those spaces. Because that's a really fantastic surrogate for us to understand if a space is a high risk or if it's a low risk. And in our OzSAGE Safe Indoor Air guidance that has been released previously, we actually provide some numbers, so parts per million trigger limits of carbon dioxide to use to determine if additional measures are necessary. So we would advise that if carbon dioxide concentrations are not below 800 parts per million and we have no other way of getting more fresh air into that space, then that would be the point at which we would recommend the use of things like portable HEPA air purifiers.
Great, thanks, Kate. We've also got a question for Dr. Miller. You referred to the risks of people deteriorating rapidly at home while in the hospital at home program. Are there examples of people being put into that hospital at home program inappropriately?
Thanks, Kathleen. I'll clarify that the people that I was talking about having died at home, I wasn't categorising them into whether they were in the hospital and the home program or not. Whether there are people who have been put in there inappropriately, time will tell. We need to hear from the clinicians involved there. They're under contractual obligations to not speak about what's going on in their workplace, but anecdotally we're hearing that there are people who are dissatisfied with the way the program is running. So whilst I can't directly connect any of these deaths to inappropriate referrals, I think what we need is a lot more data, a lot more transparency, and to hear from the patients, the consumers who have a right to expect and not to be left behind as to what their experiences are. And this is a great role, I think, for the media to be out there asking for people's stories to come forward, because we as a nation come to expect that when we ring 000, we will receive assistance. But in many cases, it seems as though those services are really stretched, and we understand that the government is saying we're going to be overwhelmed. That is one thing to recognise that, but it's another thing to plan to head in that direction. So to plan to overwhelm your system, I would be happy to say is inappropriate. Thanks.
I might ask the question around data and information regarding mask wearing. So one of the things that we've heard from all of the speakers today is that there has been, I guess, limitations in the data and information and transparency around that. So do we have any information around what masks are being sold and used in Australia? And I'm just kind of wondering if there's, I guess, availability of that information for the public researchers and government. And it might be for the mask team.
Okay, so at the moment, I guess if you went to a pharmacy or if you went to just any sort of store that the public could access, you can easily obtain surgical masks, other types of respirators such as N95, P2 respirators, KF94, sometimes KN95, sometimes of varying quality. It's really important that you look to see that that product is certified. There are guides available to help, but generally these are different types of respirators and masks that are being used in healthcare facilities and in industry. So I want to make that point because we have heard historically some commentators say that we should preserve those types of masks and respirators for our healthcare workers. And I think it's really important to discern the difference between what you might purchase at a pharmacy or a store is traditionally very different to what is being provided in a medical setting, where they are being provided N95 medical respirators and other types of respirators with very large supply agreements in place. So I think the supply and stock of the respirators and masks that Jeremy were referring to can be easily accessed by members of the public to help keep us all safe.
Anyone has any additional questions as well, they can get in contact with the media team. So any information or if you want to ask any of the experts about anything else, please get in contact with us. And these are the details online.